Good afternoon, everyone, and thank you all for joining us. I would like to welcome you to the first roundtable of the academic year. My name is Brendan McMullen. I'm a first-year student at SAIS and this year's coordinator for the Development Roundtable Speaker Series. The Development Roundtable is a high-profile speaker series where leaders and scholars within the international development sphere address our community on trends and challenges shaping the field. Before we get started, I want to go over the setup of this virtual webinar. This event will be recorded and we'll be answering the questions submitted with a Q&A feature. Your name will automatically be visible if you submit a question, but please indicate the organization you are from, just like you would if this were an in-person session. We're going to save Q&A for the end, but you can enter your questions into the Q&A feature at any time. Today's Development Roundtable is in partnership with SAIS Global Women in Leadership and the Georgetown Institute for Women, Peace, and Security. On behalf of everyone in the IDEV and SAIS community, I would like to welcome our esteemed guest, Dr. Geeta Rao Gupta. Geeta is a global leader on health and gender and will be discussing a recently published article in the Lancet about how the global health community can and should do a better job of responding to the deeply embedded gender norms in health interventions. Geeta is currently the executive director of the 3D program for girls and women at the United Nations Foundation. She is also a member of the World Health Organization Independent Oversight and Advisory Committee for Health Emergencies, and serves as the commissioner on the Lancet Site Commission on Gender Equality, Health, Peace, and Justice. Previously, Geeta has served as the co-chair of the Gender-Based Violence Task Force at the World Bank, deputy executive director at UNICEF, and president of the International Center for Research on Women. Finally, I would like to acknowledge some of the other panelists we have on this webinar today. We have Dr. Tanvi Nagpal, director of the SAIS International Development Program, and Cori Bennett, a student leader of SAIS Global Women in Leadership. I would also like to thank Chloe Adcock, the former Roundtable coordinator, for planning this event today. I will now hand it over to Corinne, who would like to say a few words.
Hello, my name is Cori Bennett, and I am the Director of Events for the Global Women in Leadership Organization at Johns Hopkins School of Advanced International Studies. GWIL equips SAIS students with the tools and knowledge they need to excel in their careers and tackle challenges facing women worldwide. We are so happy to be part of this event. And I will now pass it off to our speaker, Dr. Geeta.
Thank you so much, Corinne, and thank you, Brendan. Thank you, Chloe. And thank you, Dr. Nagpal, for inviting me today. I'm really grateful for this opportunity to share the work that me and my colleagues have done on gender equality, norms, and health. It was more than a decade ago, actually, that, can I get my slides up? That would help. Thank you. Thank you very much. It was more than a decade ago when WHO's appointed a commission to look at the social determinants of health. And that commission established unequivocally that the gender inequality plays a determining role in health outcomes. And despite that, the role of gender inequality and restrictive gender norms in contributing to health inequities and poor health outcomes has received very little attention in terms of actually addressing those problems. So why is this important now? There are two big reasons. One, we now have the Sustainable Development Goals, of which there are two goals, SDG 3 and SDG 5. SDG 3 for universal health coverage and SDG 5 for the gender equality and the empowerment of women, both of which demand that there needs to be a greater understanding of how gender norms intersect with other social stratifiers like race, caste, class, ethnicity, sexual identity, to create stubborn inequalities, and how those in turn affect health outcomes for women, men, and for gender minorities. So we cannot realize the ambition of the Sustainable Development Goals 3 and 5 without understanding these links. And it's particularly important now because we are living through the COVID-19 pandemic, which has drawn attention to the ways in which the virus differentially impacts women as compared to men, with higher rates of mortality among men and a spike in domestic violence experienced by women as just two examples. There are many others. And we've also seen how the virus has intersected with race and class to result in disproportionately poorer health outcomes for those who are Black and brown and those who struggle to make ends meet. So today, what I'd like to do is to underscore how important it is to understand the role that gender inequality and norms play in determining health outcomes by describing the findings of the Lancet series that was published in June 2019. I hope you'll all get yourselves a copy. It's entitled Gender Equality, Norms in Health, and it laid out recommendations for what needs to be done by the global health community to recognize and transform gender norms and reduce gender inequalities in everything that the global health community does in order to assure positive health outcomes for women, men, and gender minorities. Can I have the first slide, please? The next slide, please. Yeah, so you can see that I was just one of many, many authors of that series. The previous slide, please. This is a large group of researchers from all over the world, led by Dr. Gary Darmstadt of the School of Medicine at Stanford University. There were a set of 5 papers in the series that lay out through extensive empirical analysis and literature reviews how gender norms can be protective or harmful to health and can influence health behaviors, health systems, and even health research. So for the talk today, what I will do is draw heavily from those papers, but in particular from the first paper in the series, with many thanks to Lori Heisey, who incidentally is a professor at Johns Hopkins University, and Margaret Green, who together with their co-authors wrote the first paper in the series. And that's the paper that lays out the concepts, the conceptual framework for the series. And then I will draw upon, of course, paper 5, which was the paper that I co-authored together with Nandini Uman, Karen Groen, Catherine Kahn, among others. And that's the paper that lays the way forward. So with that, let's start at the very beginning with definitions. The next slide, please. So gender, as you can see here, is a social construct, and it defines the roles, responsibilities, entitlements that are associated with being male or female in any society. By doing so, it defines the distribution of power between and among women and men, girls and boys, and gender minorities, and that in turn intersects with other social stratifiers such as age, race, class, ethnicity, to create a hierarchy of advantage and privilege. Next slide, please. So then, what are gender norms? Gender norms are the often unspoken rules that govern the attributes and behaviors that are valued and considered acceptable for females and males in any culture. They are learned and reinforced from childhood onwards through a variety of mechanisms: observation, instruction, positive and negative sanctions, and through institutions, social institutions such as media, religion, and other social institutions. Sometimes they can be seen so pervasive that they appear to be natural or somehow ordained and therefore immutable. Restrictive gender norms are those that consider only a narrow range of gender expressions or behaviors as acceptable. Individuals who then do not conform to those prevailing restrictive gender norms may be subject to severe negative sanctions. And a good way to illustrate this, just for fun, is if you will look at the two hands, your own two hands. This is an example used by Lori Heisey and Margaret Green and their co-authors in paper 1, and I love the example. If you look at them, left and right, they are hands. In that sense, they're the same, but their position and function in relation to the body and to your world is not neutral. We clearly value the left and right hands differently in our world, and phrases such as left-handed compliment and right-hand man clearly reflect this different valuation. So it's the same with gender norms. Feminine and masculine is associated with a hierarchy in which typically masculine and all that is male is superior to feminine and all that is female in most societies. And that is why gender inequality and restrictive gender norms lead to inequities in health. Let me explain that further. The next slide, please. So here's where it all begins. And this is possibly what comes to mind when you think of gender norms, right? So here's a pictorial depiction from a children's book that was published in the US in the 70s to show how in no time at all, you grew up with these messages differentiating girls from boys. So boys fix things and girls need things fixed. Next slide, please. This is the conceptual framework that the series based its analysis and research on. It shows how gender norms create inequalities through multiple pathways to affect health outcomes. I'd like you to read it from left to right. And at the extreme left is the sex that you're born with. And that's determined by your genes, your body features, your hormones, your genitalia. And those conditions within you, that biological sex, can cause sex-specific health outcomes, such as sex-specific cancers, let's say. So prostate cancer versus ovarian cancer. So health outcomes that result from sex-specific biological differences and characteristics are called health differences. Health inequities refer to unfair and avoidable differences that arise from structural disadvantage through the gender system, which is depicted in the second part of this slide. That's the influence of family, community, policies, and institutions that overlays on the biological differences the expectations for behavior, roles, and responsibilities, communicating thereby what is valued and who has power. And in short, that's what creates a gendered person. And that then creates structural disadvantages and inequalities, the cost of which is often borne by women, but limits the possibilities also for boys and men, contributes to homophobia and stigma around transgender or non-binary individuals as well. And then those are further influenced by other social stratifiers, which is the third part of the center of the slide, which is race, class, age, ability. Those are additional sort of axes of stratification that intersect with gender so that some are more privileged than others. And sometimes, therefore, privileged women, wealthy women, have more power than marginalized men. And then the final section of the slide, which if you can get the next slide, will show you in greater detail. The next slide, please. Are the gendered pathways to health. So that gendered system and that gendered person then, how do those inequalities affect health? And these are the pathways that lead to that. The first is gender differences in exposure. Because of their socially ascribed roles, men, for example, are more likely to work in physically demanding jobs, such as mining or heavy manufacturing or construction, whereas women are more likely to be in the care or service sector and more responsible for domestic responsibilities. As a result, men are more likely to be harmed by exposure, let's say, to chemicals or to acute traumatic injuries from heavy lifting or from falls. And women are more likely to be exposed to, let's say, cleaning compounds, textile dust if they work in garment factories, hair dyes if they work in beauty parlors, and develop conditions like asthma or muscular disorders because of repetitive movements, perhaps. So there can be different outcomes based on your exposure, and that exposure in turn is affected by your gender role. There are also gendered health behaviors. So notions of masculinity that are now referred to extreme masculinity, that are called toxic masculinities, cause boys and men to behave in ways that sometimes harm their own health, such as not seeking healthcare, reckless driving, substance use, and serious aggression. The norms of femininity, on the other hand, which can also be called toxic feminities, expose girls and women, for example, to sexually transmitted infections because of multiple sexual partners in order to gain acceptance and love, eating disorders, and violence. It's important to note that some norms of femininity in certain settings can also be protective, such as norms that limit the freedom of women, limit them from smoking or drinking or from sexual expression, can in fact have positive outcomes on health. Next slide, please. These are the gender barriers, which is a third pathway to access to health services, to health care. Girls and women, more than men, typically face these gender barriers to access because of the way in which gender norms define women's and men's domains. So women, for example, often have less access to financial resources, and so cost becomes a barrier. And men and older women are often gatekeepers for women's access to healthcare. And sometimes the husband's consent is required for the provision of certain types of treatment. In other cases, shame or other negative sanctions may prevent men from participating, for example, in child health services or in seeking help for their own health. And we know that men who have sex with men may fear retribution if they seek treatment or information, let's say about HIV or other sexually transmitted infections. So there are gender barriers to access that is a third pathway. Next slide, please. This is to show you that health systems themselves are gender biased. And in fact, there are two facets to any health system. It's the interactions with clients, which is on the left, and with patients. And the system also interacts with its workers, right? And places workers in different jobs. So there's two sides to that health system. And gender bias works to influence both. Because essentially the health system replicates the societal gender inequalities in the way in which it treats patients and communities and the way in which it places its workers. I really like this particular illustration because, and I want to acknowledge the contributions of Catherine Hay, Lotus McDougall, Valerie Percival, Sarah Henry, Anita Raj, among many others, for coming up with the right side of this diagram, which is particularly effective as far as in describing what I'm trying to say, which they call the cure versus care paradigm. A paradigm in which women get assigned to caring roles as nurses, nurses, midwives, or frontline community health workers, and men to the curing roles as physicians, surgeons, etc. With the curing roles clearly being more valued by health systems, they're paid more, they're higher up in the hierarchy of the health system than the caring roles, which results in women being paid less and sometimes being asked to work free, as often happens with community health workers, and because they're presumed to be working for altruistic reasons, as if they don't deserve payment, and with very few women in leadership roles, even though they form the majority of the public health workforce. There's a statistic out there that's been doing its rounds, which is that 70% of women in public health, of people in public health are women, and 25% of leadership roles are held by women. Next slide, please. And then this is the last pathway, which is the gender bias in health research. This particular slide talks about clinical research, but it's true in public health research as well. And this is a bias that has been documented for years. It's only now being recognized, and attempts are being made to rectify this in selections of samples and the way clinical trials are done. Also, journals are beginning now to change and to look out for, ways to sort of measure and quantify how many of the articles they publish are written by women versus men, how many succeed in getting grant funding, etc. Next slide, please. So despite all of the evidence to back up all that I've said so far on the impact of gender inequality and restrictive gender norms on the health of girls and women, boys and men, and gender minorities, very little has been done to address these issues in the way in which they impact health inequities. And I think it's primarily because of three persistent myths that you see in front of you. The first is a stubborn refusal to incorporate a response to the social determinants of health, because there's a continuous, this commission that I talked about happened more than 2 decades ago. And yet, when you talk to health professionals in global health institutions or in national ministries, they always see the social and economic determinants of health as being somebody else's job. And that is unfortunate, because then that leaves out the impact of gender inequality and restrictive gender norms. The second is that norms are so culturally entrenched that people truly believe that they cannot be changed, that they're somehow immutable, that they're always going to be with us, and it's too big a task for development interventions to try and change them. And the third is that even if we were to change them, there's no real way to measure that change, or there's no real way to measure which norms currently are active. And the series really, in a compelling way, has dispelled each of these myths by clearly laying out the pathways from norms and inequalities to health outcomes, by demonstrating using quantitative data and proxy measures how norms can be measured, by using surveys and other methods to sort of not just capture attitudes and beliefs, which is one part of norms, but by specifically identifying what are called empirical gender expectations and measuring those, which is what I think others do, and normative gender expectations, which is what I think others expect me to do. And by summarizing the different ways in which gender norms can and have been changed. So I think the series was a contribution to the field because it provided some hard evidence to dispel these persistent myths. So then the question remains, next slide please. Can gender norms change then, right? That was the big question. So if you can go to the next slide, we have plenty of research now showing yes, they can, and there are certain levers that can be used to change gender norms. And the first of these is policies and laws. They can make a huge difference to catalyze change in gender norms. For example, tuition-free education for girls in many countries actually increase the number of girls and the acceptance of girls going to primary school and even secondary school. Another example is parental leave policies in organizations instead of just maternity leave policies has sort of forced the issue of men getting more involved in childcare. So those are just two examples, and the series lays out a number of others. The second is through social movements, by mobilizing and organizing at the grassroots level, by organizations, advocacy coalitions, that can have enormous impact to draw attention to an injustice and then lobby decision makers to create those laws and policies to rectify the inequality. The best example in recent years obviously has been the marriage equality campaign for gay marriage, but the one that I talk a lot about is the women's movement, which has been a global movement for more than 3 decades now, or 4 decades, I should say, which forced the world to recognize that gender inequalities exist and are unfair. This is, in fact, the month of the 25th anniversary of the 4th World Conference on Women that was held in Beijing. That was a momentous occasion for women's rights because for some reason we needed to get the world to agree that women's rights are human rights, and that was where it was agreed to. And that was the result of the efforts of a social movement that we call the women's movement. The more recent example is the Me Too movement or the Time's Up movement on sexual harassment, the Men Engage movement against male violence, and of course the hashtag Where Love is Illegal campaign that promotes LGBTQ justice. So that's a very effective way to bring about change in norms. A third is through programs and program innovation. And there's been a lot of that kind of innovation and experience with programs and evaluation research to back it up to show that these interventions do in fact succeed in shifting social norms. And those depend mostly on getting communities together because it's communities that set a norm. So to get them together to do some critical reflection by educating them that norms are collectively constructed and therefore can be collectively changed, and making sort of pledges to change them together. And there are several examples in the literature of that. The fourth one is through the media. Advertising as a sector has long recognized the power of media messages in shaping norms. I'm sure you're all aware of the way in which alcohol and cigarette companies, just to give you 2 examples, have very carefully crafted ads over the years to make drinking and smoking more desirable. Smoking not so much now in the Western world, but they're using the same tactics in the South, and you have, they're targeting particularly younger smokers, younger people and women. And it's interesting because they've done that so effectively you can actually link those media messages to increases in these behaviors. Yet global health campaigns that seek to promote healthy behaviors, such as less smoking, or giving up smoking, hasn't used those same tactics. And that's a shame, because I think media can make a big difference. And we have some progressive companies who have promoted more recently equitable gender norms. I'm sure you've seen this. Dove soap has the body image ad campaign for women to show that you don't have to be a particular shape and size in order to feel beautiful. There's a beautiful series that you should all try and find online called the Ariel Laundry Detergent Campaign in India, which is hashtag share the load, which is very clever and won many awards. The more recently, the Gillette ad campaign, which is called The Best a Man Can Get, which sort of questions the definition of masculinity. So I hope that we can use the creativity of ad agencies and that technique to shape gender norms more. In fact, one of the things that occurred to me when I was preparing my remarks for this afternoon was, wouldn't it be great to have them do some really good advertising around the use of face masks today. And then finally, I put on their external shocks. Now, this clearly is not something we have control over, but they do have enormous impacts on gender norms. And the example that's most often cited is World War II, where when men went to war, women entered the workforce. And then when men came back, although women were forced back into the home, they began to recognize what's possible. And with the book Feminine Mystique and other things that happened around that time, began to demand their rights. It's the beginning of the women's movement for equal rights here in the US. But I have to say that the shutdown because of COVID may see a similar shift. And we're beginning to get some data on that in the sharing of household work and childcare between women and men, because everybody's at home now and these responsibilities have to be shared in order to be managed. So there are researchers who are documenting those shifts. It'll be interesting to see how sustainable those shifts are once society opens up again, which we hope will be soon. Next slide, please. The next slide, please. Yeah, thank you. So this is key actions that are listed in the series that need to be taken at a sort of macro level to address gender inequality more broadly. I'm really going to focus, I mean, you can look at them. I'm going to focus on two in greater detail, the first one and the fourth one. But let me just quickly go through the rest. Obviously, we need to reform the workplace and the workforce, particularly in global health. So we need to figure out a way in which we have health professionals who understand the difference between sex and gender. In doing this series, I was horrified, frankly, to learn that medical students aren't taught the difference and cannot define for you what the difference is between sex and gender. To help health researchers see the way in which they can measure the impacts of gender versus sex. All of those things are important, but also the way in which we design the workforce and what we value and who we pay how much, and how do we get women to be in leadership positions in global health. There's an excellent organization now called Women Lift Health that is promoting women's leadership in health organizations, and we're hoping that that will catalyze some change in that arena. In terms of data gaps, there are huge gaps in data on women as compared to men, and certainly very little data on gender minorities. There's an initiative called Data 2X that's housed in the UN Foundation that is seeking to fill some of those gaps, or at least identify them and work with statistical institutions within countries to get them to fill those gaps. Ultimately, it's the civil registration and vital statistics systems that have to begin to be strengthened in order to make that happen. And I know that there are global initiatives attempting to do that now. I'll talk about the civil society actors and social movements in a minute. And then finally, accountability mechanisms. We need to hold people accountable. Corporate entities who put forward messages that are damaging to health outcomes because they promote restrictive gender norms. We need to find a way, and there's one entity, Global Health 50/50, that is currently holding global health organizations accountable for addressing gender inequalities, and that's the kind of thing we need more of. So let me now dive in a little more into the first one, which is the focus on health outcomes. That is what's been happening in health, as in most of international development, is that the approach to addressing gender within organizations has been called gender mainstreaming. It's the approach that has been used since the Beijing conference. And it was thought of as being the approach that could rectify the inequalities between women and men, rectify the power imbalance through changing policies, programs, but also changing operations and the way in which organizations are designed and organized. It hasn't had the desired impact. In fact, we have very little information on whether it's had any impact on the lives of women and men, on actual outcomes and impacts in the field. And what we've learned through various critiques and analyses that have been done of gender mainstreaming is that it's failed in many different ways in its implementation. The vision of it was right, but in its implementation, it was sort of made synonymous with women. So the health sector thought, well, we always deal with maternal health, we deal with reproductive health, so of course we're responding to gender. But that completely misses the relational aspect. It misses the fact that there are gender norms that have to be changed. And so they missed the boat on that one. In terms of architecture for gender mainstreaming, the way it's implemented in most organizations, it's very expensive and cumbersome. There have to be gender focal points in every department. And often those gender focal points are generalists. They're not sectoral specialists. So they don't necessarily have credibility within the sectoral departments, nor do they have an impact. And it's become, in general, a very prescriptive ideological approach, which then turns into a tick the box exercise because it comes from the top down. You have to do this, it's mandated. And so people cut and paste paragraphs from reports to say they've addressed this particular gender inequality without having any conceptual clarity, without having any real impact. So in a way, gender mainstreaming, because of the word mainstreaming, means everywhere, everything. It's actually gone nowhere and done nothing much, is my particular belief. There are people who would argue on the other side with me. So what we are pushing for now, me and a subset of colleagues, is a more problem-solving sector-specific approach, where development professionals instead are motivated to integrate a gender perspective into their analysis because it will help to solve a problem that they care deeply about, while guided by an overall vision of gender equality is the right thing to do. So we need something much more practical, much more specific, that identifies specific gender gaps or specific problems caused by gender inequalities or by restrictive norms. And we need to be very clear on how to fix that based on evidence. And that's what should drive the integration of a gender perspective into responses of organizations. I can answer more questions on that later. And then in terms of civil society actors and social movements, just to say that there's a very shrinking space, as you're probably all aware, and very restricted funding for civil society action. And yet we know that much of the success on women's rights, for example, has come from the grassroots movements around the world. So, you know, that's what resulted in the UN Decade for Women. That's what resulted in the Convention for the Elimination of All Forms of Discrimination Against Women. All of the key resolutions within the UN came out of the work of the women's movement. And right now, civil society movements are under threat in a big way. They are, you know, Civicus, which is a civil rights, civil organizations, civil service organizations, not civil service, civil society organizations. It's like a network. They did a study where they found that civil society rights are now seriously restricted in 109 countries and only 4% of the world's population currently lives in countries where their rights are widely respected. We know of the backlash against civil society organizations working for gender equality. It occurs every now and then because essentially these organizations are threatening the status quo. They're threatening the power imbalance the power balance that currently exists. So they get very little funding, these organizations typically. In fact, we came across a statistic that showed that from 2015, in the year 2015-2016, gender equality funding represented only 4% of the total bilateral aid from OECD DAC. So we've been arguing for a while that predictable multi-year funding is what is needed, and that it should go to grassroots organizations and women's organizations who made movements happen, who made change happen. The whole attention to violence against women, for example, came from women's action at the grassroots level. So the Canadian government, together with Melinda Gates and the Bill and Melinda Gates Foundation, have set up now the Equality Now Fund in Canada, which is actually going to be funding grassroots organization, is already doing so. And the UN has the Spotlight Initiative to tackle violence against women, which also supports grassroots organizations, that's funded by the EU. Those are the kinds of initiatives we need more of. Can I have the last slide, please? The last slide, please. Thank you. So ultimately, though, this is political. Changing the power balance in society and equalizing that balance between women and men is a political business. So it requires much more than technical fixes. But I believe that the moment is right to do this now. If you can go ahead and just click so that we get the full slide. And I say this because, as I said before, we have a journal like the Lancet focusing on gender and health more than ever before. Not just the series that I talked about that was last year, but they've just put another commission in place on gender equality, on gender and global health specifically. And so to have a mainstream medical journal that reaches medical professionals emphasizing the role of gender and health is a good thing. It means that this is the time to act. The SDGs clearly makes it imperative that we act now. We have social movements and the use of social media to create those social movements that have been very powerful and that can mobilize and catalyze change. Let's take advantage of that. Activism for the rights of gender minorities is much more visible and mainstream today than ever before. Let's take advantage of that. And we have new champions now who are joining the field, challenging the effect of toxic masculinities on men. And those champions are men. And that has had an enormous impact as well. So I want to end by saying that the most important opportunity we have right now is the COVID pandemic, because it has directly shown us how gender inequalities and the ways in which they intersect with other social stratifiers can result in poor health outcomes. So I want to end with that thought, that on that optimistic note, that we can make a difference and the time to act is now, and it needs all of you to pay attention to this issue. Thank you so much. Over to you, Brendan.
Thank you so much, Geeta, for that extremely informative presentation. So now we're going to open it up for Q&A. I would like to direct everyone in our audience to the Q&A feature where you can type in your questions, and I will moderate them and present them to Geeta. So we have the first question from a student of staff member at SAIS. So the question states, we're looking forward to including the draft. Is it possible to set up an interview with you after the presentation?
That's great. I'm looking forward to it too.
And then if there's any other questions, please type them in the chat. If not, I do have a question myself, if you would like to answer. So you briefly mentioned that women share a disproportionate role of the caregiving responsibilities during the coronavirus crisis. Do you think this is going to have a negative impact in the post-pandemic era? If not, or if so, how do you think you're going to address this? You mentioned that it's being more shared between men and women. Is this necessarily the case everywhere? Could you just elaborate a little more on that?
Yeah, I think when I was talking about women bearing the burden of care, I was talking within the health system, that women who are in the lower rungs of the health system in COVID right now are bearing a lot of the burden of the care, as well as within the home because of the sort of increased burden of care at home. But yes, there is some indication now that because men and women are both home and both facing the same household care burdens, there is a trend now where men are doing more. It's been one of the most stubborn inequalities to shift, which is the household care burden. The share that falls to women has remained always disproportionate to that taken over by men. Even though it's moved some over the years, it's moved very little. So I'm just hopeful that now that there's a trend towards more childcare, at least happening by men, that this burden will be shared more.
Perfect, thank you for that. We have another question from Sylvia Cabas, a SAIS alum. She wants to hear more of your thoughts on measuring women's empowerment.
Measuring women's empowerment. Yeah, that's a big field in and of itself. It is complicated because you have to measure agency, right? Empowerment comes from agency, the ability to shape your own destiny. And so there are tools that have been created. I know Anju Malhotra wrote a book actually, on ways to measure empowerment and to characterize it, that you can look for. It's got to do with not just how much you earn and how much mobility you have, but it's how much of a choice you have in where you go and how you spend the money. So it's about that decision-making ability and the ability to shape the outcomes of the resources you have access to. So it goes beyond equitable access to resources to the allocation of those resources, and whether you have any control over that is typically how empowerment is defined or agency is defined.
Perfect, thank you. We have another question from Camille Sachs, another SAIS student. She says, I know that you're hopeful for action on gender norms in health today. How do you argue for a focus on gender norms given the competing priorities such as malnutrition among children, pandemics, et cetera, for funding?
I don't think these are competing priorities. I don't think you can address malnutrition and any of the other health problems. I think it's an integral part of those problems. That's the point I'm trying to make, that I don't think this has to be a standalone effort. You have to constantly, in analyzing even an issue like malnutrition and the intra-household distribution of food, how do gender norms affect that? How do gender inequalities affect that? That's the analysis that has to be infused into everything that we do in looking at health outcomes and understanding what to do about them. So I'm not suggesting that you put those aside and address this instead.
Okay, great. We have another question from Vikram from SAIS. Where does gender inequality stack up against other social stratifiers in expanding health and other inequality outcomes in developing countries? Are there some broad patterns that emerged in your analysis?
That's a tough one. I don't think you can list which one is more important or less important. I know that class plays a huge role. So whether you have access to your basic needs are met or not, and how does gender inequality play this? So there's some data to show that gender inequalities are more stubborn and greater among the middle class, for example, who hold on more to those norms. Whereas among the poor, where you're struggling to survive and sending a woman out to earn, or a woman sort of doing everything she can to earn, is more accepted. So gender norms in extreme need can break down. And that's the kind of extreme external shocks that I was talking about earlier that can change gender norms and shift the way in which men and women play roles in society. But it's difficult to create a hierarchy by race and class, and I think it's very context specific. And there is some information that compares gender inequalities with class, and clearly privileged women do better than poor men, for example, in access to resources or in voice and participation in society. So it is important to look at those intersections. It's one of the mistakes we made early on, is not giving intersectionality the emphasis it deserved. And I think it's a lesson we've learned.
Thank you for that answer. Chloe Adcock, one of our panelists, also has a question. I think she's going to go ahead and turn on her camera to do so.
Hey, Chloe.
Thank you so much, Geeta, for that presentation. Just on that last comment, I just wanted to add, I was taught in Women's Studies 101 that we shouldn't rank oppressions. So I just thought I would throw that out there. So my question is regarding your comments on civil society and the need to provide multi-year funding to build capacity in grassroots organizations. I find that really interesting. And do you see this starting to actually gain traction and practice? And what are the most promising examples of that you've seen? Because it seems like development donors traditionally tend to be quite prescriptive in the projects that they fund, and they want to fund specific results and outcomes.
Yeah, you're right. Project funding is what is most preferred by donors because they're looking to get very specific outcomes that they can predict in advance through a theory of change, and that's the more traditional way of funding. But I think increasingly donors are realizing the importance of capturing the innovation that exists within these organizations by allowing for more unrestricted and organizational money, to strengthen those organizations so they can take advantage of opportunities that arise to make a difference in their local context. But it's still very limited. I mean, philanthropy in this regard hasn't shifted that much. And I think, attribution of money to results is so important for those who give money. And I understand that. And it's very difficult when you give it to an organization for the organization to be able to prove that your money resulted in this outcome, because it gets pooled then with other money that comes into the organization. So you can't put your flag on an outcome and say, this was from my country, I gave you this money. And that becomes the issue. So there is now new efforts to sort of pool resources of different donors. There's an initiative called Co-Impact that is innovative philanthropy at its best, that allows for private foundations to pool their money together to bring about large-scale change, systems change, because you need much more money in order to do that. And that's going to Southern organizations who are coming up with the innovations themselves. It's very evidence-based so that the donors can feel confident that their money is actually going to create some change. But it's going to need more advocacy and more proof that this can work, that it does work to bring about change. Philanthropy has often been very directive. When the talent actually lies in their grantees, they often think that they know the solution to the problem. And because problems are often so context specific, you need people who live in that context to be able to solve that problem.
Thank you.
We have another question from Professor Roman here at SAIS. He's wondering if you can go a bit deeper into the role of communication in the gender mainstreaming effort and gender norms. What role they like communicating to government counterparts, the civil society, et cetera.
So sorry, say that question, last part again?
What role does communication play in the effort in gender mainstreaming and gendered approach to health?
So if you mean communication as in internal communications, or you mean communications as in media and advertising? That's what I wasn't sure about.
I think both would be great to be answered.
Okay, gender mainstreaming within organizations, I can tell you the communication that is vital, and there's several studies to prove this, is from the leadership. Okay, so whoever's the leader of the organization, if that leader clearly specifies a vision that is uncompromising in its requirement for paying attention to this issue and to this particular determinant of health, then it's more likely to happen that the professionals within that organization will pay attention to it. That ingredient seems to be the one that is critical. So that communication and how it's done, not as, it has to be inspirational. It has to be something that motivates, and then it has to be supported by organizational processes, incentives, etc., that would support those changes in behavior. In terms of communications externally to change gender norms, extremely powerful, but extremely powerful in shaping the normative context, but not sufficient. So necessary, but not sufficient is what I would say. It is one tool. I worked for many years on HIV/AIDS, and I can tell you that communications in HIV prevention were extremely powerful, extremely important. How we did it was important, but it wasn't sufficient. It had to be backed up with interpersonal interactions, good services, etc. So it's not enough to just have communications in order to change norms. It's a powerful tool that I think global health hasn't used enough. That's all. That's the point I was trying to make.
Thank you. We have another question about how can you incorporate a gendered approach into sector-specific interventions, whether that be sanitation or food policy. What advice do you have to people that are trying to do that?
So to do that, you need sector specialists who understand gender analysis. And that's what we have lacked in the field. We've had a lot of people who are gender experts, but if you don't speak the sectoral language and don't understand the sector specifically, so in water and sanitation, there are so many issues that are gendered, right? I'm just giving you a few, that the sanitation needs for women are very different from men. Women collect water, men don't in most rural settings. So how do you respond to a problem you're trying to solve? So if you're trying to figure out where to put the water point in a community, who should you be talking to the women or to the men? That's the kind of, it's a simple thing, right? And it's often not done. So if you talk to whatever is the local village council, it's typically only men, and they'll give you their perspective, which is not going to give you the perspective of the actual users of that water point. So it's just, and to get that into the understanding of water and sanitation specialists and to get them to respond to that in the way in which they design programs, you need to have somebody in the team that is cognizant of those gender differences and inequalities and speaks the language of water and sanitation. That's my personal feeling, because otherwise you don't influence programming as much as you could. You're otherwise seen as an outsider who has a sort of personal ideological commitment to something and is not going to help them achieve their results. So I think sectoral specialists who have the gender expertise is what is needed now. And actually it's interesting, in UNICEF, partnered with George Washington University to set up a program called Gender Pro, where they're training sectoral specialists within UNICEF on gender analysis, but in a sector-specific way. And we need much more of that. This general gender training that occurs in organizations, I don't think does the job.
This is going to be our last Q&A of this session. This is from Katie Henry, staff from KSAS undergraduate at Public Health Studies program. She's wondering what your thoughts and suggestions are for women who want to continue into leadership positions within the public health field. What's working against them? How can they balance work and life to get there? And are there any words of advice that you have for undergraduates or graduates in that regard?
So what the research shows is that lots of women joining the public health organizations and the field in general. And they get up to a point, and that's the intersection between their reproductive years and middle management, and then they drop out because the institution doesn't have the policies to support their promotion into leadership positions. And by that, I mean sufficient flexibility in work and time arrangements, work-family arrangements, the ability to be able to take longer maternity leave yet not lose your place in the hierarchy. So there are specific institutional policies that can be put in place to benefit women to stay on in the profession. So as a young student, I would say to you, when you join an organization, ask the questions of what policies they have to support women's advancement, and look at how they recruit. Their recruitment processes that you can put in place so that you don't just recruit men all the time. Is the pool that you pick from evenly divided? Ultimately, you have to pick the best person for the job. But if you start with a pool that's only men, then you're never going to be able to hire a woman. So there's various things within organizations that can be done right. And the field is changing, is what I'd say to you. There is greater recognition now. There's even a demand for women in senior positions. So if you're just starting out, I think the world will be a better place for you.
I think we actually have time for one more question. We have one from a SAIS faculty. If and when a COVID-19 vaccine becomes available, what would be your recommendations to governments and health agencies in ensuring access to the vaccine?
What becomes available? I missed that.
COVID-19 vaccine.
Vaccine becomes available. Yeah, that's a whole other ballgame. Yeah, I would say health workers should get priority, and among those health workers, that they should prioritize those who are at the bottom of that scale, because there are a bunch of nurses, midwives, sanitation workers within hospitals, women who are sweeping the floors, who are clearing out the dustbins and garbage. Those are the people who are exposed on a regular basis to the virus within those settings. And I hope that they will be considered in the definition of healthcare workers. I know that they're prioritizing healthcare workers, but I worry about those who are doing all of the support jobs that don't get seen as healthcare workers, and yet they are the ones who are exposed. So I would say that that's what I'd like to see as a priority. And then of course there are the teachers, there's all those essential functions, all those women and men who have been out there, whether they're the grocery store workers or serving us while we've been protecting ourselves. And I would like to see them get priority for the vaccine. And I hope that's what governments will decide to do.
Thank you so much for that answer. And thank you so much for your timely and informative presentation today. We greatly appreciated it.
Thanks a lot. Bye-bye.
Bye. This is going to be the conclusion of today's roundtable. We have a few more roundtables planned for the rest of the semester. We have an event on October 22nd with Dr. Marie Ruel from the International Food Policy Research Center. And on October 9th, we have Mr. Michael Schlein, the President and CEO of Axion. Thank you all for joining us today.